Welcome to this exam preparation video focused on the short case of lipoid proteinosis. This video is divided into two parts: clinical performance at the bedside and examiner Viva questions. Part 1 focuses on clinical performance. We will cover the examiner's command, how to describe the facial lesions, critical findings on the eyelids and oral cavity, the relevant examination, and how to structure your differential diagnosis. The examiner says to you, examine the face and do relevant examination. Give your differential diagnosis. Before you approach the patient, ask the examiner's permission. If the patient is a minor, seek consent from the parent. This is not optional. The moment you start, state the general condition first. You say, "Thank you. My patient is a young girl sitting comfortably on the couch, well cooperative throughout the examination." Then follow this order every time: distribution, type of lesion, surface findings, associated findings. Do not jump to a diagnosis. There is diffuse and bilateral symmetrical involvement of the face, extending from the forehead down to the neckline, and also involving the ears. The skin appears waxy, with pock-like atrophic scarring distributed over the face, predominantly over the forehead, cheeks laterally and symmetrically, and the chin, with sparing of the nasal tip. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. Erosions and crusting are present along the forehead, pinny, and the neck. There are areas of post-inflammatory hyperpigmentation and hypopigmentation. I would like to pinch the skin to assess for induration. Palpate for induration, temperature gradient, and tenderness. Also ask the examiner. I would like to ask the patient their name. If the patient is a minor, seek parental consent before proceeding. Now, the critical findings. On examination of the upper eyelids, I can appreciate beaded papules along the margins of the eyelids. This is Moniliform Blepharosis. There is also sparseness of the lateral eyebrows. This finding is pathognomonic. If you see it, it points directly to lipoid proteinosis. Then move to the oral cavity. On examination of the oral cavity, I can appreciate cobblestoning of the oral mucosa. There is protrusion of the tongue with a thick, short frenulum, consistent with restricted tongue movement. The tongue appears tough and indurated. Then add, I can also appreciate blistering erosions over areas of trauma. And if examining the body, waxy papules are present over the elbows and knees. Each of these findings builds your case. Do not omit any. I would like to examine the rest of the skin, including the axillae, elbows, and knees for waxy papules. I would like to examine the scalp for alopecia. I would like to examine the eyebrows for matarosis and the eyelid margins for moniliform blepharosis. I would like to examine the eyes, checking for conjunctivitis, photophobia, and corneal opacities. I would like to examine the oral cavity for cobblestoning, macroglossia, and infiltration of the teeth and gums. I would ask the patient to protrude the tongue to assess the frenulum. I would like to assess the voice for hoarseness, and if present, request microlaryngoscopy. I would like to examine the genitalia for waxy yellow papules. I would like to palpate the liver and spleen for visceromegaly. I would like to perform a chest auscultation. I would like to perform a CNS examination, including assessment for nerve palsies, trigeminal palsy, and any neurological deficit. I would also perform an auditory examination. Now state your differentials, in order, with reasoning. My differentials include, first, lipoid proteinosis, the waxy skin, pock-like scarring, Moniliform blepharosis, cobblestoning of the oral cavity, and restricted tongue movement. This is the complete picture. Second, Hydroa Vacciniforme, photosensitivity, vesicles, crusting, and scarring on sun-exposed sites. However, it does not account for the Moniliform blepharosis or the oral findings. Third, Erythropoietic Protoporphyria, EPP, photosensitivity with skin thickening on exposed areas. However, it lacks the characteristic eyelid and oral findings of LP. State your reasoning. Do not just list names. The examiner is listening for clinical logic. Part 2 focuses on examiner Viva questions. We will cover the cause, genetics, pathological mechanism, confirming the diagnosis, histology, neuroimaging, named signs, and treatment and prognosis. The examiner asks, what is the cause and genetics of lipoid proteinosis? You answer, lipoid proteinosis is an autosomal recessive inherited disease. It is caused by a mutation in the ECM1 gene, extracellular matrix protein 1, located on chromosome 1q121. The examiner asks, what is the pathological mechanism? Mutation in ECM1 leads to dysfunction of extracellular matrix protein 1. This results in abnormal deposition of hyaline material, a PAS-positive diastase-resistant substance, in the skin, mucous membranes, and internal organs. The examiner asks, how will you confirm the diagnosis of lipoid proteinosis? Diagnosis is confirmed by histological and ultrastructural analysis of affected skin. Skin biopsy shows PAS-positive, diastase-resistant hyaline deposits. Genetic testing for pathogenic mutation in the ECM1 gene provides a definitive diagnosis. The examiner asks, what does neuroimaging show and why is it relevant? Neuroimaging, brain MRI or CT, shows intracranial calcifications in the temporal lobes or amygdala. This is relevant because these calcifications are associated with neurological manifestations, including seizures and behavioral changes. Additional investigations include microlaryngoscopy to assess laryngeal deposits, ultrasound abdomen, and skin biopsy for immunofluorescence. The examiner asks, what are the eye lesions called in lipoid proteinosis? The eye lesions are called Moniliform blepharosis, beaded papules along the margins of the eyelids. This is a pathognomonic finding of lipoid proteinosis. The examiner asks, what is the most characteristic oral finding? Thickening of the tongue frenulum, leading to restricted tongue movement, and ankyloglossia-like presentation, combined with tongue toughness and cobblestoning of the oral mucosa. The examiner asks, what other ocular and facial findings may be present? Conjunctivitis, photophobia, corneal opacities, ptosis, ectropion, anterior uveitis, episcleritis, and restricted extraocular movements. Facial deformity may also be present. The examiner asks, what are the complications of lipoid proteinosis? Hoarseness of voice due to laryngeal infiltration. This can cause respiratory obstruction. Neurological complications. Seizures and behavioral changes from intracranial calcification. Restricted tongue movement affecting speech and feeding. Skin scarring and disfigurement. The examiner asks, what is the treatment? A multidisciplinary approach is required. Genetic counseling. For laryngeal involvement, vocal cord dissection or microlaryngeoscopic excision of deposits, though hoarseness often persists. For cutaneous lesions, CO2 laser for eyelid lesions, dermabrasion for scarring, chemical peels, and physical therapy. Systemic options include oral DMSO, acitretin, etranate, and penicillamine. These have shown beneficial effects. Oral cavity and gum infiltration requires dental review. The examiner asks, what is the prognosis? The condition progresses until early adult life, then stabilizes. Lifespan is normal in most patients, except where CNS or respiratory involvement occurs. Early intervention for laryngeal disease is important to prevent obstruction. The examiner asks, what is Hydroa Vacciniforme, and how does it differ from Lipoid Proteinosis? Hydroa Vacciniforme is a rare photosensitivity disorder presenting with vesicles, crusting, and vacciniform scarring on sun-exposed sites. Unlike LP, it lacks mucosal and eyelid infiltration. Management includes photoprotection, narrowband UVB desensitization, oral keratin, and immunosuppressants such as azathioprine and cyclosporine. The examiner asks, what is EPP, and how does it differ? Erythropoietic protoporphyria is caused by deficiency of ferrochelatase, the FECH gene. It presents with painful photosensitivity and skin thickening on exposed areas. Investigations show a peak at 633 nanometers and raised fecal protoporphyrin. Unlike LP, it has no eyelid or oral mucosal findings. Treatment includes sun protection, oral beta-carotene, a familantide, and genetic counseling. Before you go into that examination room, carry these points with you. Lipoid proteinosis is autosomal recessive, ECM1 gene mutation on chromosome 1q21. The pathognomonic finding is Moniliform blepharosis, beaded papules on eyelid margins. Waxy skin, pock-like scarring, cobblestoning of oral mucosa, and thick frenulum complete the picture. Confirm with skin biopsy, PAS-positive diastase-resistant hyaline deposits, and ECM1 genetic testing. Neuroimaging shows intracranial calcifications in temporal lobes or amygdala. Prognosis. Condition stabilizes in early adulthood. Lifespan normal unless CNS or respiratory involvement. No cure. Management is multidisciplinary. At the bedside, always ask permission before approaching. If the patient is a minor, seek parental consent. Pinch the skin when infiltration is in your differentials. Say, I would like to examine, and I would like to request. Go in prepared, go in structured.